20 years ago, when I started in this field of, hormones, women's health stuff, I could count on one hand the number of women that I would see like in a year with PCOS and endo. And now it's daily that I'm seeing somebody with these hormone dysregulations.
Hello and welcome back to the Vibrant Wellness Podcast. I'm Dr. Emmie Brown, here with my brilliant and insightful colleague, Melissa Gentile. Do you have reservations about using hormone replacement therapy for women with heart disease or who are at risk for it? What if there was a way to do it safely and effectively? What if hormone replacement could even decrease the risk of heart disease? Today, we are so excited to welcome Deidre Arms. Deidre is a dedicated functional medicine nurse practitioner with a passion for holistic health and wellness. Today, we're discussing an oftentimes misunderstood yet vital women's health topic, bioidentical hormone replacement therapy, and its role in cardiovascular health. We can't wait to break down the evidence, challenge outdated misconceptions, and explore how functional medicine provides a more nuanced, individualized approach to hormone therapy with Deidre as our expert guide. Thank you so much for being here, Deidre. How are you doing?
I'm doing well, thank you, and really happy to be here.
Likewise. Okay, so before we jump into BHRT, do you mind sharing a bit about your personal health journey and kind of what led you to this moment?
Absolutely. So at 46-year-old, I really hadn't imagined that I would experience what had happened to me, but I had a spontaneous coronary artery dissection. They call that a SCAD. And I was active. I was aware of my health. I really didn't have any major warning signs beyond fatigue that most of us women do that I had been pushing through. And then one day I just woke up with this severe heartburn that I had never had before. And as the day progressed, I just continued to feel worse, blacking out, this pain in my chest that radiated to my back. So I was with a friend of mine and we had went to lunch. I didn't cancel her because she never cancels me. So I was like, I'm just going to go. Luckily, she had this cardiovascular background too. So I had got up to go to the restroom, and when I come back, I was just like, man, it hurts all the way through. And she was just like, that's it. We're going to the ER. And so we did. And, when I first got there, it was all this, oh, you have heartburn, things like that. I'd done some testing and nothing was coming back really positive. But then I had some elevation in my troponin level, and it ended up getting me admitted. And so I got transferred to a larger hospital. And when I got there that evening, I had another provider come in and she said, do you know why you're here? And I said, yeah, for a heart cath. And she goes, no, that's not happening. And dismissed me. And I sat there all night, just really not feeling well. I was so sick. The next morning, I met the cardiologist, and him and I had a heart to heart. And even then, he had thought this was like pericarditis, and he was going to send me home. And I said, well, I'll go home, but if you turn off this nitro drip and my blood pressure raises, you're cathing me, I'm not leaving. And so I ended up getting cathed. And during the cath, I heard him say, she's dissecting. And the reality of what was happening hit me so hard. All I could think was, I need to see my kids. I need to see them in case this doesn't go so well. I thought about, my family members who I'd lost to cardiac disease, their struggles, kind of the lack of options that were given to them. It was just that moment of fear that took over me. And I just felt like the weight of the whole hospital was just sitting on my chest then. And when I got through all that, and after my recovery, I kind of started to dive into the research. Why did this even happen to me? Could it have been prevented? And I also thought back to my own medical history. So when I was 29, I had a complete hysterectomy for endometriosis. And that decision abruptly ended my body's natural hormone production. And so at that time, I was told estrogen was optional, but no one warned me about the long-term cardiovascular risk of hormone depletion. And that's when I started like questioning the conventional narrative around women's cardiovascular health, hormones and risk factors. And there's studies that have shown that severe hormone fluctuations, like those caused by early menopause, hysterectomy, postpartum shifts, they're linked to a higher risk of SCAD. So that abrupt loss of estrogen and progesterone for me, especially at that young age, may have created an environment where my arteries just become more vulnerable to the dissection. And so after that, and that whole experience, it really just led me to dive deeper into functional medicine and really investigating bioidentical hormone therapy, not really as a risk, but as a potential protector of my vascular health.
So, what actually triggered you to go explore the BHRT for yourself? And then, what kind of response did you get back from your own providers at this point?
So, I was in menopause, 46. I had had the hysterectomy. I'd been having hot flashes prior to that. And I was like, something has to give. How can I optimize health? How can I explore this longevity for myself? And as you know, when you're in this conventional model, like, people are afraid of hormones. They're afraid of what they've heard about them and risk of them. Um, so I just dug into the studies and I was like, I know what's right for my body. And luckily, I have an amazing cardiologist. We've become friends through this whole event. And he actually said to me, "Are you on hormones?" And I was like, "Not yet." And he said, "Well, you need to be." And that
Oh,
to me was like, I found my person, who understands the studies and was on the same page as me.
he's kind of the outlier then, because this common misconception does persist that hormone therapy is dangerous for the heart. And so I'm wondering, and I really want to just take it down to square one, Deidre. Why does this belief still persist? And can you take us back to the WHI? Tell us what that is, how maybe it was misinterpreted, and how providers are still a bit confused here.
Right. So the belief that hormone therapy increases cardiovascular risk really stems from that WHI study in 2002. And it reported an increased risk of heart disease, stroke, and blood clots in women using HRT. But that study was um, critically flawed. We have reanal- rean- reanalyzed that and everything, but in the study, they used synthetic hormones, right? The WHI used conjugated equine estrogen and medroxyprogesterone acetate, and those are synthetic progestin, which does not act the same way as bioidentical hormones. The age of the participants, the average age was 63. So these are women who um, had already had a decade past menopause. So they were already at higher risk for cardiovascular disease. And then when we dig into the research later, when they analyzed those younger women, 50 to 59, who started HRT within that 10-year period of menopause, they found a reduced cardiovascular risk instead of an increase. But despite the findings, the initial WHI results led to really widespread fear and medical hesitation, with many clinicians still avoiding HRT based on outdated information. And when we look at breaking down kind of the latest research, how BHRT can be cardioprotective, so that's in contrast to what the WHI said. But the up to date research shows that bioidentical hormone replacement can protect against cardiovascular disease when it's properly prescribed. So, estrogen has a role in our vascular function.
Hmm.
Um,
I was just going to ask, how does estrogen influence the vascular function?
Right. It stimulates nitric oxide production. It promotes vasodilation and relaxation of the vessels and improves circulation. So we have that endothelial protection there. It also reduces oxidative stress and those pro-inflammatory cytokines. So they're key contributors to the arterial plaque buildup. So it has an anti-inflammatory effect. And then we know that estrogen increases HDL, our good cholesterol, and lowers our bad cholesterol, reducing our risk of atherosclerosis. So there, there's a lot of benefit to estrogen. I know it gets deemed the bad kid on the block, but there's a lot of heart protection, bone protection for use of estrogen, having estrogen in the body.
But we want this to be within a certain range, right? Because we almost hear the opposite, I feel like, with younger women with estrogen dominance often.
Right. And estrogen dominance, there's several ways you can be estrogen dominant. You can be estrogen dominant because you have too much estrogen. You can be estrogen dominant because you don't have enough progesterone. And you can be estrogen dominant where you have enough estrogen, but the ratio of estrogen to progesterone is off. So those are ways that you can be estrogen dominant. And also looking at that, the microbiome has a huge role on that when we look at beta glucuronidase and how we recycle those estrogens. So it's not just estrogen isn't good for you or we have too much estrogen and estrogen dominance. It's like, where are we imbalanced? What's going on here? And trying to really help the woman who's experiencing those more high estrogen symptoms.
Mm. Would you say that's why it's really important to be testing hormone metabolites and not just getting like a serum level?
Yes, actually, because with serum, we're pretty limited, right? I mean, we can get a good baseline, like, if we do a luteal phase estradiol and progesterone, we can kind of look at that balance, see what's going on. But when you get into really the nuances of each hormones, you really look at the metabolites to look, are we more down the protective pathway? Is somebody down that 16 hydroxy that's proliferative? Is that why they're having heavy bleeding? What's going on there? What can we do to help shunt to the more protective? So the metabolites, and looking at that and what we say, like the drain and the funnel and how you're methylating those hormones is really an important piece to optimizing hormones.
And why is bioidentical progesterone, like, how is that different from synthetic progestins? I know you kind of mentioned this a little bit earlier, but can you kind of explain the distinction?
Yeah, and that's always a good question because the synthetic progestins, which are your medroxyprogesterone acetate or norethindrine, they're chemically altered to bind to the progestin receptors, but also affect androgen and glucocorticoid receptors, leading to pro-inflammatory effects. So they're linked to an increase of clotting risk, endothelial dysfunction, and negative effects on the lipid profile. And in 2018, there was a Journal of American College of Cardiology kind of reviewed the synthetic progestins and showed that it counteracts estrogen's cardiovascular benefits. And that's why, when you look at that, it's explaining why synthetic hormone therapies have worse outcomes than bioidentical. And with the bioidentical progesterone, that's your micronized progesterone.
Mm-hmm.
It's chemically identical to the body's natural progesterone. So it supports vasodilation, lowers the blood pressure, and it doesn't have an increased clotting risk. So unlike the progestins, it doesn't interfere with estrogen's protective effects on the blood vessels. So this distinction is really crucial because many times providers just kind of lump all the progesterone therapies together, failing to kind of recognize that bioidentical progesterone has heart protective properties to it.
Yeah, I think you made a good point there because I think getting the bioidentical, the micronized progesterone, it's sometimes really challenging to get that from a provider or a practitioner if you're not going to kind of the correct person, whether they're not comfortable prescribing it or just not trained in it. I've definitely seen that. And kind of going off of this, are you seeing an epidemic of low progesterone? I know that's something I wanted to touch on.
The answer is hands down yes. I feel like almost everybody coming in and you start to listen to their story and you're looking at their age and you're like, it sounds like you have estrogen dominance, but it's because you're not making enough progesterone.
Mm.
Why do you think we're not making enough?
I don't know if it's environmental, if it's food is medicine, but there's definitely a lot of hormone dysregulation going in, the xenoestrogens that we're seeing. What is playing a role on this decrease in progesterone that we're seeing in women? But I'm definitely seeing leaps and bounds more women with PCOS and endometriosis. 20 years ago, when I started in this field of, hormones, women's health stuff, I could count on one hand the number of women that I would see like in a year with PCOS and endo. And now it's daily that I'm seeing somebody with these hormone dysregulations.
That gives us so much perspective, and I think it's validating to hear for some that there is more investigation that needs to be done. And I want to circle back to that lifestyle and dietary and environmental aspect, Deidre. Before we do that, though, I think it's important to nail these safe and effective parameters, if you will, and of course individualize these things. So I want to know about this window of opportunity that you speak to for initiating BHRT. What is this ideal timing, and why does it matter so much?
Well, the window of opportunity theory suggests that if we start BHRT within the 10 years of menopause, we get the most cardiovascular protection, right? Um, if estrogen is introduced early, it helps maintain the endothelial function and prevent atherosclerosis. If it started later, it might not provide the same benefits for cardiovascular health. So I always really try to educate women when they come in, and maybe they're not ready for HRT or they think they can handle the symptoms, but hands down, we see more cardiovascular disease than we do breast cancer. Like cardiovascular is the number one leading cause of death in women. So really understanding that the hormones play a role in protecting our heart and vascular.
Hmm. I'm curious, before we move on, Deidre, do you ever start women before menopause, pre-menopause, or maybe let's say perimenopausal women who have maybe a personal history of heart disease or family history concern? Does that play a role for any of your patients?
It does. I have patients, and that we take an individualized approach, right? I'm not out here saying everybody who's perimenopause, we should start on our HRT, but really looking at the whole patient. What's their lifestyle? What is their family history? What symptoms are they having? How is it affecting their quality of life? And when I take into account everything like that, there are individual women that are in perimenopause who are skipping periods that I may start on just a little bit of estrogen and progesterone, knowing that they may have a bleed and cycle, and then I can counsel them on different ways, to mitigate that. When they do have a cycle, we kind of hold things. And so there's ways to do that, but so that they feel optimal and they're not suffering through menopause.
And obviously, there's an art to it because you are so much customizing this, which is what we need in functional medicine for best outcomes. So I so appreciate that.
Yeah.
And then what about route of administration? This also matters. So this classic example of transdermal estrogen versus oral estrogen.
So I'm a huge proponent of transdermal estrogen because it bypasses the liver. So we miss that first pass metabolism there. So I think when we look at the studies and we look at the benefits of estrogen, I think the transdermal route really gives us the most comfort. So if you're new to HRT and everything, the most comfort you're going to have is looking at those studies for the transdermal and considering those.
Gotcha. And I'm curious, I don't have this on when I prepared for this, I didn't have it, but monitoring these patients, I think because there's such a unique approach depending on the patient, how often are you monitoring labs? obviously we need to clinically correlate. We want to treat the patient, not the numbers, but are you routinely running urine hormones? Are you focusing on serum for monitoring? I'm curious what your approach is, generally speaking, for lab monitoring.
So if someone's already in menopause, right, I might do a serum to start because insurance may pay for that. We can just kind of get a baseline and get that FSH, follicular stimulating hormone, get a baseline. But then when I start to use a little estrogen in them, I really want to look at what that estrogen's doing in those metabolites. So that's when I really get into the dried urinary testing. Plus, I want to look at their stress hormones, right? Because if you are stressed, wired, and tired, and your cortisol is dysfunctioning or you have HPA axis dysfunction, you're going to have a harder time going through menopause. So we need to look at the adrenals, and we actually need to address that as part of your hormone therapy. So.
Mm. When you're thinking about these hormone therapy plans, like how do you talk to patients about things like diet, exercise, stress management? How does this play a role in the whole outcome?
Well, first, BHRT is a powerful tool, but it's not a magic fix, right? It works best when we combine it with lifestyle interventions. So we do talk about sleep, diet, exercise. For example, a diet that's anti-inflammatory, like the Mediterranean diet, high in omegas and fiber and polyphenols, really enhance estrogen's vascular benefits. Processed foods and high sugar diets worsen the endothelial dysfunction and can counteract BHRT's benefit. It's kind of like that same thought of I can't out supplement a poor diet. I can't out hormone a poor lifestyle as well. And then exercise, aerobic exercise enhances nitric oxide production and it reduces insulin resistance and improves that hormone metabolism. So strength training is what I recommend. It helps preserve the bone and helps improve metabolic health. And those also are influenced by estrogen. And then when we look at stress and sleep, that cortisol dysregulation, right? It increases insulin resistance and inflammation, making hormone therapy less effective. That's why we have to deal with the stress piece of things. And quality sleep really supports our hormone balance and our cardiovascular recovery. So we have to address all of those things. That needs to be part of the whole plan with bioidentical hormones, especially if we want to optimize them and use them as this powerful tool that they are.
I did have one question that you kind of just made me think of is when you're seeing patients and you're starting them on these BHRT plans, are you seeing any type of correlation over time in your experience of women coming in who have been on birth control and synthetic hormones for extended periods of time in their youth, needing hormones later in life, or doing better, doing worse? Is there any correlation that you've picked up on clinically?
I have. So I have many women who will use contraception until they hit menopause. And when women hit that menopause, and it's kind of like, oh, the guidelines say you're 51, stop doing this, right? And they take women off. And what I see in that situation, especially, is it is really life altering for these women to be in menopause when they were getting even that synthetic in their birth control and having it taken away. And then they have providers that are like, oh, well, you're in menopause and you're female, and not addressing the actual menopause they are in. So I had a recent woman, 52. That's what happened to her. She was on the Nuva ring and her life was good. And then they were like, oh, you're 51. You have to come off. She's seeing me now, and we, did the workup, individualized the plan, everything. I put her on bioidentical hormones, a topical. I just got an email from her in her portal yesterday, how much better she feels. And, it's those stories is definitely contraception care and having those synthetics. Jolene Brighton wrote the book about coming off from birth control and that post-birth control syndrome and everything. That's a real thing that women are
Yes.
experiencing. And so we have to really think about that. And then especially if they're in this perimenopausal range when they're coming off from that, that's another layer to things that they're having to deal with.
You had mentioned the HPA axis dysfunction. I think I read in one of Dr. Laura Bryden's books the correlation between extended use of some of those contraceptives and HPA axis dysfunction coming off of it, or like cortisol dysregulation can be like an after effect. So I can only imagine what that's like at that age as well. All of those things kind of compounding and layering one after another on top of each other.
Right. And I've had women who like have worked the same job 25 years and have to quit because they felt what they call crazy. And I always say, don't ever call a woman crazy. Like, we just say that, you know, they're a little edgy when they go through menopause.
I like that word better. That sounds better.
You feel a little edgy and things just don't seem right. But when you're trying to, you know, express that to a provider who really isn't versed in HRT or menopause, it really just gets dismissed. And I have heard so many women say, well, they told me my problem was I'm female. And I'm like, that's not a problem. It's not a problem at all.
And that's a whole nother podcast, right? The philosophy behind this and the history and the societal stigmas and all of that. It's really crazy. And I shouldn't say crazy. Well, I mean, that's crazy, but that's the appropriate use. It's all of that stuff we have to deal with and conditioning. And to clarify, Deidre, it sounds like I'm just, the irony of all this is hitting me right now. Someone who's on hormonal contraception for, the majority of their adulthood, and then they're pulled off of it. I imagine you're saying this, it's this abrupt kind of, they're getting hit with this kind of rebound, perimenopausal symptoms, right? Because it's not that it wasn't a gradual thing for those individuals like it is for people who weren't taking hormonal birth control prior, right?
Right. It wasn't a gradual thing. It's so abrupt for them. And especially to be at that age where, you know, they're menopausal and like the guideline is 51, take them off of these. That's kind of what just happens in the traditional model of things. And then they're just left to kind of just hugely drop the hormones and just not have any support. And it's so discouraging for women. And most of them are at the top of their careers. These women are like high functioning, running their households, like juggling so many things in their life. And then here they are, like just the rug pulled out from underneath them.
No one prepares us for that.
Yeah.
And I imagine a lot of providers who are prescribing that birth control are not maybe, as you said, well versed in BHRT options. Hopefully they're listening and educating themselves if they're interested. But I want to circle back briefly. You mentioned xenoestrogen. So in this lifestyle conversation, do you have that conversation with your patients in terms of plastics and phthalates, and how do you approach that if so?
Yes, we do have this conversation. It's kind of getting to know your patients and having these conversations. But we talk about, are you, using plastic water bottles? What kind of deodorant are you using? What are you putting on your skin? There's just so many ways that we're introduced to xenoestrogens. And I will say, I really like the Vibrant test right now for hormones because it shows the BPA. And I've had that like shock some people when they see they have an elevation in BPA and they're like, well, I thought I read that. I thought I wasn't doing that. And I'm like, you're exposed somewhere. So like, let's pick it apart and figure out where and decrease that risk of even that. So we do talk about that and educate and just, how can we be optimal with our health and what makes us the best version of ourselves? So, and all of that is, you have to layer it. Like, I can't just have the patient who comes in who's not done all of these things. And all of a sudden I say, well, you have to get rid of this X, Y, and Z and don't do this. That doesn't work. It's not helpful for them. It doesn't help them to grow as a person or even felt heard. So I usually start like, what changes are you ready to make? And like, where do you want to start and build the conversation? But most of the time, over time, a year, 2 years, like, I see them getting rid of their, plastic water bottles they're bringing in. I see them, changing what they're wearing, telling me about the skin products that they've found, using the environmental working group for their skin products now to find things. So it's that building a relationship with your patient and helping them just kind of navigate what is truth out there, what is not, what can we do, what is personalized for them.
Right. And choosing our battles. I think when we talk a lot about environmental medicine, it can be doom and gloom. And I like to just remind providers and patients that it's impossible to completely avoid all these toxins, but we can do, the reasonable things like switching to stainless steel, right? Pyrex or glass, food storage containers, and focus on our own health and well-being and detox pathway support and all that. So, that's very helpful. I wanted to ask about maybe one of your favorite patient cases, Deidre, in which you used a holistic approach. And so I'm curious, are there any more details for that case or another case that you can share with us in terms of what you did holistically in addition to maybe BHRT and the outcome there?
So, yeah, a lot of times, and with that case specifically, I looked at the microbiome as well.
Mm,
A lot of the symptoms that were occurring had to do with the microbiome. And sometimes, you can't optimize hormones until you fix the gut and
Right.
improve that. So, looking into that and digging a little bit deeper, I have different stories about patients like PCOS who wanted to get pregnant and optimizing their progesterone levels and hormones and helping them to rid things that are causing xenoestrogens and that estrogen dominant picture in their life. So I have lots of interactions with people that I think it just boils down to making sure that we're addressing everything in their life. My patient yesterday, I had seen her several times and she goes, I'm feeling so good. She had been on this journey 10 years before she had seen me. And I was like, really? And she goes, you know how we were talking and you said, I might want to check out this mold thing. She goes, well, I had mold. You were right. And she remediated and that started to improve her health. But it's just really just listening to your
mhm.
patients and kind of connecting with them, allowing them to have space to heal and tell their stories. And, I oftentimes ask, like, when's the last time you felt well? And that kind of guides us to like what happened within those few years post feeling well. Like when you felt well at age 8, but you didn't feel well at age 10, what happened? You know,
Mm.
We sparked a question with that case right there. Have you had success increasing progesterone naturally, or do you always go in with like a bioidentical micronized progesterone?
I've had lots of success doing it naturally, lots of success with Chase Tree, Vitex, there's several other things that I use to detox estrogen and looking at detoxification, DIM, calcium deglucarate, things like that. So I've had lots of success that way. I often, talk to women about like if they're wanting to get pregnant, we always talk about the life cycle of a follicle is 100 days. So you need to give this 100 days of what we're doing to know if this natural thing is going to improve. Like ride it out, hold it out. Let's see what's going to happen with this before you give up on this and say it's not working. So if you're doing natural with your patients, always encourage them, write it out. If they're really like, I need to see immediate results, I might do a combo. I might do the natural, but maybe add in some luteal phase progesterone to start and things. And I may even start topically. It just depends on, you know, if they've taken progesterone in the past and maybe had some increased anxiety with it or some side effects in that range. So there's different ways to kind of do it depending on what they've experienced in the past or what they've tried or what their preference is. So
And what about supporting estrogen naturally? Do you ever use, and I want to list these off for listeners, most popular ones, maca, sage, maca more so for testosterone, sage, kudzu, which was a new one for me, ashwagandha, black cohosh. Do you ever use those? And do you use them adjunctively, kind of like you just said, for progesterone with hormones?
Yeah, I use them all the time. And sometimes in perimenopause, like we'll start there. Let's kind of optimize with what we can with the herbals and because there's this fluctuation every month brings about a different symptom for women in perimenopause, and there's these highs and lows. So using a natural approach can be really beneficial at that time. And then sometimes I'll use a combination. Let's say they're like, I'm a little worried about estrogen. I heard these things, and then you educate. But then I might say, if you're ready, we'll try a little bit, and we'll still use these herbals, and we'll do kind of a combo. So I've had great success many ways over the years.
Yes, love the artistry there, and that's who I want to find for myself. When I'm at that period in my life, I'm always kind of keeping an ear out for this open-mindedness that I'm getting from you, Deidre. And so it's really nice to witness that, and I think listeners appreciate that, and maybe they're providers who are wanting to get into this. They can probably appreciate that there's a lot that goes into this experience and training and open-mindedness again to individualize. So thank you for that. And that leads me to, we're wrapping it up here. You're so succinct and articulate in your answers. This is fantastic. We're jam-packed with information. I want to know, what should healthcare providers be doing differently when it comes to evaluating BHRT for their patients? If they're maybe listening and they don't even know where to start with their intake and their risk assessment, what would you advise for those folks?
Well, first, stop using a one size fits all approach. I know we have algorithms for everything, but this is not an algorithm based type of treatment. So, individualized medicine is really key here. You want to evaluate the risk factors properly, right? So, if you're instead of just dismissing estrogen outright, do an advanced lipid and inflammatory testing on your patients. Really dig into that and see the risk. The menopausal, that men quality of life kind of questionnaire, is a validated survey that they can use to kind of start things off to see where their patient's symptoms are. And then consider transdermal over oral routes, because that transdermal estrogen avoids the first pass liver, and it's has a better cardiovascular profile. So I would say, like, starting there's some great studies out there. So look at the new stuff. Look at the WHI reanalysis, the ELITE and the KEEPS trials. Like, there's so much good information out there to support bioidentical hormone therapy, cardiovascular disease. So I would definitely say start there if you're a provider who's wanting to do that, and start to learn some of the tests. Maybe don't pick your hardest patient, but somebody who is interested in hormones and kind of on this normal trajectory of menopause. Start looking into some of these advanced testings and kind of get a feel for those and the metabolites and what you would do differently and how you would change it for your patients.
And on that note, do you have a provider training, or do you have a provider training you like to refer to?
So BHRT Academy, A4M, those are, IFM, those are my favorite trainings there. So I've utilized all of them myself. And then there's just a plethora of just wonderful information out there that we can get a hold of and look at the studies and things.
Absolutely. And then my last question, how can women advocate for themselves to their if their doctor dismisses bioidentical hormone therapies based on outdated information? I mean, and I know we want to be gentle. Like, do you advise, do you want to come in with the research, kind of lay it on thick, or maybe be a little bit more, I don't know, diplomatic? Do you have any tips there for women who maybe need to, and maybe they just need a second opinion, but how do you navigate that for women wanting advice?
So sometimes I'll say, when you're talking to your provider, right? Because many providers still rely on outdated interpretation of that. I really encourage them to ask their provider, like, what's the evidence behind your decision for me, right?
It's a good question.
That's
Yeah.
brilliant.
Yeah. We don't ask. So often we don't even ask. We just, kind of go along with their response.
Right. And then question if you need a cardiovascular risk assessment. Like, do you need a more advanced lipid panel, inflammatory markers, a calcium score? Ask them about bioidentical options also, because not all hormone therapy is the same. And, really want to consider that. And if your provider is well versed in these topics, it's easier for you to trust their opinion, right? But if they're just saying no and they can't back up why they're saying no or why it's not right for you, then I would say, find somebody who's trained in functional medicine who understands personalized hormone therapy. That's really important. And you as yourself can look into these studies and see what's right for you. But, you want to have a good relationship with your provider and you want to feel that they're looking out for your best interests. So just, it's okay for you to question. That is okay.
I think that's a really solid reminder for us that it's okay to question that.
Very empowering note to leave off on. I love that, Deidre.
Thank you.
Yeah, thank you so much, Deidre. I feel like that we needed this episode because we've talked on hormones so much before, but we've never gone really deep into BHRT and all the nuances that come with it and the link to cardiovascular disease and all the different types of hormone therapies. So if our listeners today do want to connect with you online, if they want to be a patient of yours, if they're a provider that just wants to get in touch with you, where can we locate?
So our website's Desire Wellness Group. I have a YouTube at MP Deidre where I cover heart health topics, functional medicine and wellness for cardiovascular and PAD patients. And then social media at MP Deidre, or I'm on LinkedIn, Deidre Arms.
Awesome. We'll link these down below for you guys. And until next time, wishing us all vibrant health and wellness. Thank you, Deidre.
Thank you.
Thank you so much for being here today. Don't forget to leave us a review and subscribe so we can continue to pay it forward together. And remember, the key to longevity is knowledge. Keep learning, growing, and tuning in to the Vibrant Wellness podcast to discover the latest insights and strategies for optimal health. Join us again next week. And just a reminder, this podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you heard here today.